Faculty is Dr. Krithika S. Rao. She's a MD in palliative medicine from Tata Memorial Hospital, Mumbai, and currently working in the Department of Palliative Medicine and supportive care in Kasturba Medical College, Manipal. And she's the lead for palliative care, pediatric palliative care at Manipal, Kasturba Hospital, Manipal. So, Krithika, I'm really honored to introduce you and most welcome. Over to you for the session. Yeah.
Thank you, Dr. Sangamitra Bora. It's really a pleasure to be part of this group. And I enjoy interacting every time I meet a group of new physicians. So looking forward towards today's session. Should I start with my presentation for the day?
Yes, ma'am, you can start.
Yes, please. Yes.
Okay, just sharing my slides. So today's topic, as decided today, is palliative care emergencies. And mainly when we are dealing with emergencies, I'll be going through some of the most important ones. There are quite a lot we come across in our practice, which are like an intersection between, oncological emergencies and certain emergencies that you will also find in non-oncology cases. So I'm not going to be discussing in detail of those, but very specific that we would find in our palliative care OPDs or in the emergencies where patients come up with, and if identified earlier, can prevent any other fatal complications and help to improve the patient's quality of life. So when we talk about this, as I said, it's quite a large number, where I just did a very basic classification of it based on the etiology of it mainly. So neurological being malignant spinal cord compression, raised ICT, delirium, status epilepticus, to metabolic complications, GI, respiratory, vascular, renal. Even in pain, you will have a patient landing up in pain crisis or an opioid overdose or opioid toxicity. So it's important that how we are able to identify these earlier and manage such patients. So let me take you through some of these and we'll discuss upon it further. So one of the most important that we come across is malignant spinal cord compression. It could be intramedullary, extramedullary, and it can be various presentations by which the patient can come up with. So amongst the site at where malignant spinal cord compression is most commonly seen, you'll find mainly in the thoracic, followed by the lumbar, and after that with the cervical vertebrae. And amongst the cancer cases where you'll find the maximum presentation is in breast, lung, and prostate cancers. They will tend to be, there is a lot of when you try to have a patient come to you with back pain and all, we generally tend to go further with waiting for signs and symptoms to present with. But pain is one of the most common presenting symptom for anybody with spinal cord involved. I mean, any vertebral body involvement or sign that there could be an impending cord compression. So it'll be anywhere low, mid back, upper back. It'll be a progressive pain. It'll have quite a lot of discomfort, and it'll have a very severe unremitting course. And the nocturnal pain will be the most common first symptom that the patient would present to you, saying that night is when the pain worsens, or even by movement, the pain is aggravated by coughing, sneezing. Turning in bed is difficult for them. And pain is one of the presenting symptoms which will occur several weeks before the neurological signs may even appear. And as the disease there, or as the burden increases, the pain will progress from being very localized towards being a more radicular pain, and is seen in approximately 37% of patients, along with localized spine tenderness. Then with neurological issues like difficulty in walking will be the most common presentation, followed by motor weakness being the most common symptom, radicular pain associated with it, bowel bladder involvement depending upon the level where it is involved, sensory phenomenon, or a band-like sensation at the dermatomal level where the obstruction is there. So patients, when you ask them, they'll be very peculiarly saying that there is some kind of a tight band right across, like on the waist area or in the mid chest area or in the upper part where they feel like something is constricting. So that is one of the like a trigger that would make you think that let me look whether there's some kind of an impending cord compression. So signs that we would see is in motor, spastic paraparesis, quadriparesis, which is one of the we would have when we do an entire neurological examination, you'll have motor sensory involvement, even autonomic dysfunction will be present in certain cases. So the diagnosis, we know MRI is the gold standard in detecting epidural metastatic disease or any frank spinal cord compression. We generally tend to not rely on plain spine radiographs. We think, when we look at cost versus the burden that the patient will have to bear to doing that, a plain radiograph might just tell you if there is some kind of a compression fracture of the vertebrae, but it may not give you any more details beyond that. MRI definitely is one of the gold standards. I know in our limited resource settings, in various areas, the charges that it would have, we can try and find out whether there could be other means where a simple plain scan for like a bone scan to just evaluate whether there are any bone metastasis. Areas where MRI can be done, it will be really very helpful to understand that. Otherwise, some of the very limited resource settings do go by clinical examination only and clinical signs and symptoms at presentation to really go ahead. And then probably if radiation needs to be planned, you might want to go for the CT scan, which they do for simulation, and there recognize what is happening. So there are these ways where people use it up. So the main pathophysiology behind this is that if there is an epidural tumor which will cause venous stasis, there would be a lot of secretion of interleukin prostaglandin. So at that is the reason where the vasogenic edema occurs, causing ischemia, and that if the ischemia persists, will lead to a lot of lot of cytotoxic edema forming, and that could lead to permanent nerve damage in that area. So this pathway also tells you at what level of whatever drugs that you're using for managing spinal cord compression is going to help in. So that leads us to the management part of it, where we first and foremost look at pain relief. As per the WHO analgesic ladder and severity of the symptom, it's a nociceptive pain pathway being activated. So you would use non-opioids and opioids depending on the pain severity, and adjuvants, mainly the neuropathic pain agents like gabapentinoids, tricyclic antidepressants, where if there is a radicular pain presentation. Then a patient would also present with sometimes bowel retention, that they may not be able to pass stools, there'll be constipation. So you need to manage that too. In a paraplegic patient, it is of utmost importance to develop a bowel regimen. So the treatment involved in malignant spinal cord compression, the first and foremost is the use of steroids. Among steroids, dexamethasone has been shown to have better efficacy, where the mechanism is that it inhibits prostaglandin E2 and vascular endothelial growth factor production. Therefore, it reduces the vasogenic edema and the further cytotoxic edema and damage. So high dose dexamethasone has to promote the post-treatment ambulation is a grade A recommendation in various evidence-based guidelines. So the initial dose recommended is starting at around 24 to 40. Generally, in our daily practice, we stick to giving like 24 at least a 16 milligram stat dose initially at the first presentation that the patient you would have seen in the OPD, followed by 24 milligrams divided throughout the day in 3 equal doses. And that is to be given throughout the course. And suppose if you have identified that it's a spinal cord compression, you need to start radiation, then only taper the dose once the radiation has completed, because while giving radiotherapy can also lead to a lot of vasogenic edema. There could be worsening. So to tackle that RT-related edema also, DEXA should be continued at a high dose and then eventually tapered off after the RT ends. So the RT being one of the first formers, one of the lines of treatment when we are thinking of spinal cord compression, if surgery is not feasible, like if it's a wedge compression fracture, then yes, spine stabilization is important, because just giving radiotherapy might not revert the problems. But if it is just a soft tissue mass, it is extramedullary compression, then yes, radiotherapy can help in. And the first fraction should be delivered within 24 hours of patient's first presentation. Now, generally, when we see in our practice also, we have seen that patients would have had some pain. They present very late, or they would have developed some weakness in their limbs, and they would take some time thinking that, okay, no, this is just maybe fatigue. And then eventually, when there is complete loss of power, where there is 0 by far power, they will then land up into the casualty, and already maybe 4 or 5 days would have been lost. That golden period is very important, that patients are aware of this beforehand as to when they should be presenting to the clinic with any small note symptoms that they notice. So RT is directed at the vertebral metastatic sites. It will cause at least good 60 to 90% of patients which achieve pain relief with RT alone and dexamethasone. And patients who are ambulatory before radiation therapy, 60 to 100% maintain the ability to walk. So standard radiation doses would be around 20 gray in 5 fractions or 30 gray in 10 fractions. Now, depending upon the prognosis and the intent and the extent of neurological deficits, the radiation oncologists decide the dosages that they want to give in. Another part which I talked about is surgery is recommended when patients with progressive neurological deficits are there. There is a vertebral column instability, radio-resistant tumors are present, or intractable pain which is unrelieved by radiotherapy. And in individuals where it is a chemosensitive tumor or cancer that they are suffering from, so Hodgkin's, non-Hodgkin's, germ cell, breast or prostate carcinomas, or neuroblastomas, chemotherapy is also attempted as a way to prevent or to alleviate the compression from that region. So the prognosis when we look at is this, that pre-treatment ambulatory status and the time from development of motor deficits to the radiotherapy are one of the most important predictors of ambulation post-treatment. So patients with single metastasis, a radiosensitive tumor or myeloma, breast or prostate have the longest survival. But whereas with multiple metastases, there are other visceral or brain mets, lung or GI cancers have a shorter survival. So when the emergency is when there's delay in diagnosis results in loss of mobility, bladder dysfunction and decreased survival, because there are reports that say anybody with a spinal cord compression, survival they have seen has to be next to almost 3 months itself. The survival and quality of life are directly related to the patient's pre-treatment ambulatory status. So the emergency MRI and immediate initiation of specific therapy may help in preserving this function and improving the quality of life of that person. So when we move on to the next one of these emergencies is raised intracranial pressure. I'm sure very often we come across this in our regular practice too. Many of you, I'm not sure from which background you come in from, but you may be oncologists, you may be general physicians, you might be already running a palliative care OPD, and you would be seeing that a lot of patients with brain mets, neoplastic meningitis will present with raised ICP. One of the most common symptoms that they'll talk about is headache. Some of them will present with delirium, vomiting. There would be patients with seizures, focal neurological deficits. The onset should always be acute. It will be progressive, and there could be a fluctuating course of the symptoms. You will find majority of them with lung, then breast, and then melanoma, and majorly patients with mets in the cerebral hemisphere, followed by cerebellum and the brainstem. So there are these, underneath you will see there's 2 tables that I have put in about common signs and symptoms of patients with brain mets, where they will have headache and cognitive dysfunction more. And in patients with neoplastic meningiosis with a focal or intracranial involvement, you'll have nausea, vomiting, headache. There'll be cognitive dysfunction, which may be like confusion, memory loss, followed by others like facial paralysis, diplopia, difficulty walking. So these are easily picked up, but it's one of the most important amongst our emergencies that we manage. Like all of us know that when we look at raised intracranial pressure, the first immediate is anti-edema measures to be started. Medical decompressive therapy is the first choice. And here again, we would use steroids. So dexamethasone started at a dose of 16 to 24 milligram. is given, and to stop if there is no response in 3 to 4 days. And when we look at raised ICT due to brain metastasis, radiation has been given in, we would want to slowly taper the dose by 2 to 4 milligram per day rather than a very fast taper over a few days, because that way it will avoid the effect of what do you call, recurrence of the edema and then recurrence back of the symptoms despite your optimum management. So here again, the rule states that while WBRT is being suggested for patients with brain mets, you would continue steroids until the RT is completed and then slowly taper it. And while we're doing this, especially with patients with known history of diabetes mellitus, monitor their blood sugars because we're giving very high doses of steroids. Next in line, we would consider giving mannitol for 3 days. While we do this, keep a check on their sodium levels and monitor BP and hydration. Once we have finished the 3 days of mannitol, we would generally switch over to giving oral glycerol. So while giving oral glycerol, also to be kept in mind to optimize their laxatives, patients might also have diarrhea because it has an osmotic action. So if patients are on morphine or tapentadol or tramadol while they're taking treatment, and you would want to stop those drugs, stop the laxatives if they're having loose stools. Keep in mind when we are looking at patients with brain mets, I mentioned about tramadol, you also have to look at stopping that because it can reduce the seizure threshold. We haven't used furosemide so much, but it has been there has been evidence to use in refractory cases where the edema is not reducing, patient persistently has symptoms of raised ICT, and where you could consider giving furosemide. Again, with symptoms of headache, analgesics as paracetamol and NSAIDs are the drug of choice. And here we do not recommend adding step 2 or step 3 because they have a tendency to increase the ICP. So adjuvants could be considered, like gabapentinoids can also be sometimes considered when we're looking at trying to reduce symptoms. So there could be presentations of seizure control. So accordingly, based on if the patient presents in status epilepticus, to follow that particular protocol. Phenytoin and valproate are the first line agents, and the levetiracetam is usually the second line. So giving prophylactic anti-epileptics in patients who already have a known history of brain metastasis does not have sufficient evidence and does not really prevent seizures to be presented later. So starting them on prophylactic basis need not be done in your regular practice. So same thing as we discussed about radiation doses, there is stereotactic brain radiotherapy also being considered in patients with a very isolated, maybe like an oligometastatic area, where they want to preserve the entire brain function and not give WBRT, but give a very focused. So then stereotactic brain RT is considered. Else, if there are multiple metastases, then you have to end up using WBRT. So whenever the KPS here means Karnofsky performance score, when the performance status of the patient, whichever scale you use AKPS or KPS, so it has to be more than 60 to 70. If you use ECOG, it should be around 2 to 3, so that if the patient is ECOG 4, AKPS less than 50, treating a patient with brain metastasis with WBRT may not really help to a larger extent because it's the disease burden is advanced, they have a very poor quality of life, and they're not fit for any disease modifying treatment. So the next, which brings us to the topic of status epilepticus, it's greater than 5 minutes of continuous or more than 2 seizures with incomplete recovery of consciousness. Etiologies could be varying. There could be a primary brain lesion. It could be metastasis, leptomeningeal involvement, metabolic causes, infection, withdrawal from drugs, hemorrhage, paraneoplastic, hypoxia, or any pre-existing illness. So the main treatment flow, like we would have had this in medicine, we would have had a entire training of, there would be a flow chart nicely mentioned where you look at ABC and oxygen, look at giving immediate nasal, buccal or subcutaneous midazolam or IV midazolam, thiamine, blood workup. And this is one of the measures. So when we look at first initial management, it is using benzodiazepines. Then it does not work, is moving over towards phenytoin or phenobarbital. Where if the patient does not recover out of this, then it is towards beyond into intubation, ICU care. And some of the patients who continuously, despite optimum management, persist to have continuous seizures, we might need to put them on deep sedation using phenobarbital or propofol. So I know it's like too many emergencies we are trying to cover here, but I'm trying to make up the best. So the next we have is the metabolic emergencies, where hypercalcemia, it is one of the most commonest life-threatening metabolic condition and very difficult. Sometimes a patient presents with altered behavior and we tend to miss it at times. So whenever we see any patient with any altered sensorium, it's always important we do a thorough metabolic workup, and then when very often we pick up hypercalcemia like that. So it presents maximum in lung and breast cases. And recently we have also seen patients with head and neck cancers, especially buccal mucosa. You'll find them presenting with hypercalcemia. So the clinical features that you will find is neurological. There would be irritability, there would be lethargy, sedation, delirium, stuporous, or coma. They would have a lot of nausea and vomiting or constipation presenting as symptoms. There would be polyuria. They would look very dehydrated because one, they're vomiting out, they're not taking anything orally. That would also lead to them to develop dehydration or even present with AKI. Cardiovascular, you would find that there's bradycardia, short QT, widening of the T wave, and prolonged PR, and in certain cases, even arrhythmias. So when we look at hypercalcemia, before looking at on the table on the left, on the right, I have given the idea about how do we calculate the corrected calcium, because that is your real estimate of the calcium levels present in blood, because it is bound to albumin. So whenever we see any value on reports, that is ionic calcium, but we also need to take into consideration the bound calcium. So the corrected calcium formula would be measured calcium plus 0.8 into 4 is the constant minus the serum albumin. So this gives you the corrected calcium levels. Now, any level above 10 is hypercalcemia. So 10 to 11 will be mild, 12 to 13 will be, 11 to 13 will be moderate, and any level above 13 will be severe hypercalcemia. We've had presentations of patients with corrected calcium levels of 16, 17, and at times, and that has been, if it's not picked up in right time, patients could have fatal complications. So the recommended steps that are part of the treatment protocol is, first and foremost, in mild and moderate hypercalcemia, to start with hydration. That usually we start with normal saline itself with 3 to 4 liters given IV over 24 hours. So for a practical purpose, the order could be like IV NS going at 125 ml per hour, followed by 20 mg Lasix after every 1000 ml of fluids that have been given. So that helps in correction by through of diuresis. The next in line is to start salmon calcitonin, which is given in severe hypercalcemia. So the doses recommended are 200 international units given 8-hourly subcutaneously. So that when given brings down, but we have to recommend, we have to remember that not to be given more than 3 days of total IV subcute salmon calcitonin, because then it can have tachyphylaxis. Next is suggested that use of bisphosphonates. But now, while considering bisphosphonates, we need to remember about the creatinine clearance also. So if the creat clearance of this patient is normal, then you could consider the zoledronate at normal dosages. However, patients with hypercalcemia do tend to present with dehydration leading to pre-renal AKI. That is when you need to make sure that corrected calcium levels, and if there is a need for dose adjustment for zoledronate to be given. So zoledronate is always given on the first day, and its effect would come within the next 3 to 4 days of after giving zoledronate. So you have to keep in mind that while we're aggressively trying to correct, if in severe hypercalcemia, all of these 4 steps are needed. But in moderate to mild hypercalcemia, only hydration can be enough or sufficient to manage in the initial stages. Steroids were recommended earlier, but recent evidence says that it does not really affect, and you could only consider giving salmon calcitonin and bisphosphonates. While we are trying to manage hypercalcemia, checking calcium every 12th hourly in the initial first few days, and only after 2 days or later, you'll find normalization actually happening, and 80% in 1 week. So while we're doing that, monitor the input-output chart, because the amount of fluids you're going to give in, you should maintain that the patient has enough of that output, does not have fluid overload. Check other electrolytes and venous pressure. So hypercalcemia is one of the most important that needs to be picked up, treated in advanced cancer patient, because even if the patient has a limited life expectancy, it has a greater role in controlling symptoms, because you'll reduce the nausea, vomiting, anorexia, fatigue, and delirium, and all of these symptoms in this patient when it is under control. And patients do well once it's come down to normal levels. The next, when we consider amongst the metabolites, is hyponatremia. Again, we'll have a similar presentation where they will have there'll be an altered sensorium. Initially, it will start with anorexia, nausea, fatigue, malaise. There would patients present with irritability, sometimes with muscle cramps or weakness, very rarely with seizures or coma. There are 3 types of hyponatremia, one being hypervolemic, due to hypoalbuminemia, CCF, or cirrhosis, where it's an overhydrated state. 2, hypovolemic, where it is underhydration due to vomiting, dehydration, diet, or use of diuretics. And type 3 will be euvolemic hyponatremia. It's a normal hydration state, and most commonly due to SIADH, which is one of the most common paraneoplastic syndromes seen in our oncology patients. So when you look at management for this, correction with recent guidelines suggests that it should be not more than 6 to 8 milliequivalents over 24 hours, because there's a risk of central pontine melanosis. So the diagnosis is that hyponatremia is when values are less than 135 milliequivalents per liter. Symptoms most likely will occur in graded severity once the sodium levels falls less than 120, and it can be life-threatening when it is less than 105. Now, very often in our oncology practice or in palliative care OPDs, we'll have a lot of patients coming with sodium levels within the range of 125, 128, or 130. They might have been chronically adjusted to low levels of sodium. It could be due to multiple reasons. Even hypoalbuminemia is one of the most common causes. Because of anorexia, cachexia, you'll have loss of albumin levels. So there we have to keep in mind, we need not be overtly aggressive while treating that, because that may lead to false treatment of that and would lead to other complications. So on the right, I have mentioned a basic formula that you can utilize when you're trying to do sodium correction. Going by this, it's a sure shot way that you will not overcorrect, and at the same time make sure that balance whatever the patient needs. The amount of sodium correction the patient needs is given in a very graded manner. When we talk about treatment of SIADH, it slightly differs, where we are imposing on water restriction. So the guidelines recommend not more than 800 to 1000 ml of fluid, free water taken orally throughout the day. If the sodium levels are very low, then consider giving in moderate to severe hyponatremia, consider correcting it with 3% saline. And use of fludrocortisone or tolvaptan is also suggested. Tolvaptan is given in patients where despite 3% sodium, you're not able to correct it. You can start initially at a dose of 7.5 milligram to 15 milligrams per day, and not more than a month's time to be used. So while patient is on tolvaptan, you have say initially started, and within a week's time sodium levels have come down to normal levels and they are maintained. You can stop the drug, need not be continued for a month's time. You can stop once sodium levels are within normal range. So next we move on to respiratory acute or subacute airway obstruction. It will likely be presentations would be that In subacute presentations, it would be due to an intrinsic or an extrinsic compression. It would be like an inspiratory spider or just shortness of breath. Acute with severe progressing dyspnea, hemodynamic collapse, and very severe distress with both patient and the family not able to, be able to bear the distress that the patient is having. Treatment in subacute phases would be if hypoxic use of oxygen, high dose steroids, using opioids and benzodiazepines, and radiotherapy if in case if it's due to superior vena cava obstruction, or if there is a tracheal infiltration, there is an extrinsic compression due to some neck nodes which have enlarged. So then you would consider looking at option of radiotherapy. In an acute presentation where there is severe progressing dyspnea, complete hemodynamic collapse where the patient is in severe distress, and it could likely also be presenting at end of life, there your main aim would be to educate the family, support, give them the understanding of what's happening with the patient, what are their goals, and if goals are only for comfort care and end of life care, then rapid sedation to relieve distress is one of the mainstay of management. So amongst this obstruction, you have seen about SVC obstruction, where benign cases are there in 15 to 20%, where it will be due to fibrosis or a thrombus. Malignant, it will be tumor infiltration or lymph node compression, local infiltration or fibrosis secondary to radiotherapy. Commonly seen in bronchogenic carcinomas, lymphomas, and thymomas. So depending upon the level of obstruction is where how the symptoms will be presented. So on the table below, it says that if the obstruction is above the level of azygos, the collateral veins such as the cervical veins will dilate. So you can make a guess that at what level is the obstruction based upon the signs on examination. If the obstruction is at the level of azygos, then small superficial thoracic veins will dilate. If the obstruction is below the level of azygos, so blood will black flow through the azygos vein into the inferior vena cava, and you'll not be able to see those dilated veins over the thoracic wall, but mainly over the abdominal area you will find more, and thereby the simple way of milking away the vein and then seeing the flow is from up to down or down to up will be able to help you differentiate between that. So the one of the common is it will present with facial edema and breathlessness. Headache or blurring of vision is due to cerebral and retinal edema. The shortness of breath is due to tracheal edema. And GVP is elevated, non-pulsatile, swollen face, eyelids, upper limbs, suffused conjunctiva, dusky sinuses, chest collaterals, and tachypnea is one of the signs of presentation with SVCO. So now this particular patient that you see with lifting away up the arms, there's a flushed face, there is a swollen, it may not, because you're seeing for the first time, that's just difficult to appreciate, but there is some swelling, facial swelling that you can see in this particular patient. At times, you'll also find that the entire upper limbs, the neck, the thorax, face is fully edematous, and the patient is really distressed with a puffy face, not able to breathe well. So these are one of the commonest symptoms and signs that you'll be seeing in patients with SVCO. Again, the mainstay here involves the use of anti-inflammatory, that is steroids, dexamethasone given at 16 to 24 milligram, furosemide, bronchodilators. If it's due to SVCO thrombus, then giving low molecular weight heparin will work. But it's very important to differentiate whether the thrombus is a plain vascular thrombus or it's a tumor infiltrating causing a tumor thrombus. If it's a tumor thrombus, none of these anticoagulants will help, and patient may not really benefit from any interventions, but only looking at symptom control. In rarest of the cases where the compression is external, you could consider looking at an interventional radiologist performing an SVC stenting to open up and help relief of the obstruction. At times, even radiotherapy too, like due to there's a lymph nodal mass, there's an extrinsic compression due to any other tumor mass, you could consider giving radiotherapy in radiosensitive tumors. One of the next topics is hemorrhage. So causes we know is either due to cancer invasion and destruction or due to marrow infiltration and thrombocytopenia. In cancer invasion, mainly in head and neck, there's a risk of catastrophic bleeding because of the carotid artery being very nearby to the anatomical, due to its anatomical location. So an impending carotid blowout syndrome is one of the most common fatal complications due to an hemorrhage. hemoptysis in lung cancers. GI, you'll have sudden tumor bleeds due to gastric cancers, rectal or stromal tumors, and in gynecological cancers. Marrow infiltration and thrombocytopenia seen in AMLs, lymphomas, and prostate cancer. So next would be about treatment related is patients with chemotherapy or radiation therapy might develop severe mucositis that could also lead to oral bleeding, rectal bleeding. In certain patients with graft versus host disease who undergone bone marrow transplant, they would also present with a severe bleeding due to oral mucositis or rectal mucositis, colonitis, and you'll have various presentations of it. Thrombocytopenia, use of anticoagulation. Uh, in cancer, certain centers do still consider using warfarin as one of the treatments for anticoagulation due to deep vein thrombosis. So that's when we need to be keeping in mind as to the if patients have liver liver metastasis, liver parenchymal damage, leading to various enzyme abnormalities, there could be a chance that patient is while being on warfarin can have sudden bleeding episodes, and use of other drugs like aspirin in certain chemotherapy protocols, in certain treatment protocols where they use aspirin along. So NSAIDs is one of the most important stage. Other patients, as I talked about, advanced liver disease, DICs, and acquired coagulation defects. So the management we understand about is looking at ABC, transfusion if required, tranexamic acid when you think that it's an arterial bleed, vitamin K when you consider when there's that there's an advanced liver disease, or there could be coagulation disorders, FFP, RDP required in certain cases. If it's a minor bleed like just a small ooze or blood mixed in vomitus, you might consider adding PPIs or coating agents like sucralfate. In tumor bleeds, hemostatic RT can help in a longer way. It is given in the dose of 6 gray, a single fraction. And though it can help only if it's a capillary bleed, it may not help when if it's a venous or an arterial bleed. That time, certain interventional procedures like thromboembolization might be more effective in managing an arterial or a venous bleed. So if you suspect such a patient is continuously vomiting up blood, or there is melena, or you notice there is a certain tendency that this patient might be internally bleeding, appropriately doing arteriogram will help you understand the identify the bleeder and check if you have the resources available in your area, if it's feasible to do an arterial thromboembolization for this patient. It can help at least curtail the bleeding, but I'm not sure whether how much it will affect on the overall survival of this patient, because definitely it's an advanced disease burden leading to this. So it might temporarily like kind of plug at that point of time, but overall the patient's survival is not going to be any different than what it was before. Rather, it might get shortened because it once a tendency to develop that, there's a tendency that it can happen again. So patient and the family might require education about it, explaining details, drawing up a plan for further goals, what to do in case of an emergency. So such patients where we look at, terminal hemorrhage can happen at many times, especially in head and neck cancers where there is a large neck area wound. You suspect that such a neck wound can also be encroaching internally, can cause a carotid blowout. So when we have that in we anticipate that this is going to happen, first and foremost educating the family. You can have like a small kit developed with them where you can give them access to oral opioid drugs with them, telling them that they have dark towels kept by the patient's bedside, so that in case of an episode, using a dark towel to just compress the site from where the bleeding is will at least cover up or mask the color of blood, and the patient or the other family members are not distressed seeing the amount of ooze that they would see in. By sedation, I know at home sedation would be very difficult, but we do have access to midazolam nasal sprays. So it is a 200 microgram per puff dosage nasal spray, which you can give it in hand with as a kit, part of a kit with the family members, saying that in case you notice that the patient has such a terminal bleeding or is like spotting out blood from the wound, or is from there's a massive hemoptysis, massive hematemesis, and you don't want the patient to be distressed seeing that much amount of blood oozed out, you could sedate him by giving him or her by using the midazolam nasal spray. Like it's a one puff each in each nostril till the patient is sedated. It'll at least last long enough to reduce the distress. Very often, patient this would be a fatal event. So just by sedation, you're preventing the distress, but asking them to have this kit ready, knowing what particular doctor where they can call can go a long way, because your instructions can help them in a longer way. And only thing that we can do at this point of time is just being there and trying to manage that distress, because there's no other way or active treatment appropriate or possible at this point of time. The next would be about fractures. There are a lot of patients with bone involvement, especially with lytic plastic lesions, uh, very often that they would present with pathological fractures. So there's a scoring called as Mirel scoring, which can help us identify risk. So it is used as a for risk stratification as to what to be done in case if a patient has such lytic mets and you would want to consider for the treatment. So these are based upon the points, the site, the pain that the patient has, kind of lesion it is. It's a mixed sclerotic, blastic, lytic, and the size that it is involving. It is involving more than 1/3 of the structure, or the bone involved more than 2/3. So depending upon the total score, if the score is less than 7, then there's no risk for a pathological fracture. You can leave it as is or consider radiation therapy if the pain is very severe. 8 to 15, there is increased risk. So keeping in mind about if it's in the lower limbs, so avoiding weight bearing activities on that limb, use of walker, use of crutches to walk around, not put the weight on that limb, that can be done. In the back, using Taylor's brace. Or if it is 9 to 33 scoring, then immediately we referred for stabilization surgeries. So there are prophylactic orthopedic procedures that are done, palliative radiotherapy for pain control, and adequate analgesics as needed. One of the most important, and I think one of the last two topics, is acute pain crisis. So a pain crisis is an event when patient reports to your OPD, clinic, hospital with severe uncontrolled pain that is causing severe distress both to the patient and the family. So at an estimate, it would be on a scale of 10-point scale, it will be more than 7 or at least 7. So it's a medical emergency because it can have a significant debilitating effect on the patient. So managing crisis is by use of rapid rapid titration using IV or subcutaneous morphine. It would be better to use IV morphine because you're able to grade it and immediately get the effect. Because with subcutaneous, it depends upon subcutaneous fat tissue content and the amount of time that it can take to act, and can lead to overdoses. So the prerequisites is severe pain on a numerical scale rating more than 7 on a scale of 10, likelihood of a partial or complete response to morphine. So, so the main aim would be, the first is preemptively give metoclopramide before giving IV morphine at least 10 minutes prior. Then diluting, say a single ampule of morphine contains 10 milligram per 1 ml. So we need to dilute it to the dilution of 1 milligram per ml. So using one 10 ml syringe, have the dilution in 9 ml NS, and give dosages of 1 milligram per each initial dose that you would consider giving. Give 1 milligram, wait for 5 minutes, see the response of the patient. If the patient's pain has not reduced, give another push of 1 milligram dose and wait again for 5 minutes. And every graded 5 minutes you give until the patient has a good response to pain. So on a scale of 10, if their score has come down to 3, that's where you stop, and monitor this patient for the next 1 hour in the clinic or in the emergency to see for the recurrence of pain. That is one of the way that we can titrate, and based upon the total dose that you have given, since from dose 0 or dose 1 to your to the level that suppose you require 3 milligrams of IV morphine. So when you multiply it by 3 IV morphine, you want to convert it to oral now dosages. So you will have around 10 milligram per dose. So that's how you will divide it and start them on oral morphine and then discharge them or continue admission, or if you want to change it to any other drugs. This is for anyone presenting to you for the first time. It's already if you don't have reports of their renal clearance at the initial, because pain at that point would be very important. But when we're trying to switch them over to oral or a transdermal dosage, we need to make sure that we check up on all their labs and accordingly manage for that patient. So as we talked about, one who was opioid naive, but when we are considering patients who are already receiving opioids, so the patient is taking an oral opioid converted to an IV dose. So IV to oral doses, oral dose divided by 3, and that's equal to the rescue dose of this patient. So suppose if a 10 milligram oral morphine per dose is equal to IV dose, that is reduced dose to 3.5 milligram. So you administer double the rescue dose by slow titration. But now that has a risk, because if you tend to give this is theoretical knowledge. But if I tell you about practical purposes, I would still go by the 1 milligram approach every 5 minutes, because that way you are doing a slow titration. It's safe. You will prevent any opioid toxicities, prevent overt sedation of this patient, and can easily monitor and manage, instead of giving a bolus push of 3 or 4 milligrams or 5 milligrams of oral IV morphine at this point of time. And always while monitoring, make sure you're monitoring the respiratory rate and the sedation score for this patient, because you do not want the patient to land up into opioid overdose or toxicity due to this. So the co-analgesics that can also be considered while for administration during pain crisis is NSAIDs, which is ketorolac, very, very helpful in patients with severe bone pain. And a single dose can help in a longer way to manage severe bone pain crisis. Dexamethasone in bone metastasis, neuropathic pain, nerve compression or spinal cord compression. Ketamine is given, ketamine and lignocaine challenges are given in a lot of patients with refractory neuropathic pain. It is to be given under by experienced people, under guidance, under monitoring, and only on an IP basis, because it can have its side effects while you're undergoing treatment. Patient can go into arrhythmias while giving lignocaine challenge. So it's very important that we choose and pick which patient should get and not. Midazolam is also considered sometimes when we're looking at sedation or as an anxiolytic drug while patient is in severe pain crisis and is in severe distress. Opioid toxicity, as I talked about opioids while giving, we need to also look at signs where it will be presenting, patients presenting with sedation, confusion, delirium, hallucination. Pupils will be pinpoint. Patients, some of them could have myoclonic jerks. There could be slowing of cardiorespiratory system, seizures, and cardiorespiratory arrest. So indications for use of naloxone here for reversal is when respiratory rate is less than 8 per minute, or difficult to it's less than 10 to 12 but difficult to rouse or clinically cyanose, or if the respiratory rate is less than 12 per minute but difficult to rouse with SpO2 less than 90%. So the mainstay here is naloxone is available as a 400 microgram per ml vial, which needs to be diluted. And when you're giving naloxone dosages, not more than 40 mics at one dose that you're giving first time should be given more than that, because patients can end up into respiratory arrest, cardiorespiratory arrest, if a very high bolus dose of naloxone is given. So while administering for this, dilute that entire vial of naloxone, which is 400 microgram in 10 ml NS, and administer 0.5 ml every 2 minutes until the respiratory status is satisfactory, wherein your respiratory rate, if suppose if it is less than 12, has reached at least between 13 to 15 per minute. That's when you stop and monitor the patient for 1 hour, because the half-life of naloxone is 60 minutes. There could be a chance that after 60 minutes patient would go back into the same situation of opioid toxicities. So we may need to re-administer at that point of time, or find out why the patient has developed such toxicity. Is it because of AKI? Is it because of some other liver dysfunction that the patient has had developed opioid toxicities? So while administering, every dose should be 40 mics, not more than 80 mics given in a span of 10 to 15 minutes. It's always better to wait, repeat after 10 to 15 minutes than giving much many boluses and end up with a lot of complications. So it has to be given under monitoring. Keep a regular SpO2 monitor. Keep monitoring every 1 minute, full manual count of respiratory rate. and based on that, take the clinical judgment to continue giving dosages or wait. So as a general practice, what we have done is we have seen that usually within the first 2 or 3 doses, that is 40 mics given at intervals of say 5 to 10 minutes, maximum 2 to 3 times, is when we have seen patients have reversed and they have come back to little consciousness, respiratory rate has improved, and even their confusion has settled. So we need to be very mindful when we are trying to manage when we are managing pain crisis, as well as when we're looking at opioid overdose and managing opioid toxicity. And with this, I end my talk. Thank you so much for patiently listening. It has been a very wide lecture, but I had to cover so many emergencies. Thank you for having me here.
Thank you, Dr. Krithika. This has been a wonderful, wonderful session. And I would like to open this for questioning. Any questions? There has been 2 or 3 questions in the chat, but I've tried to answer those also. But then I'm sure there'll be many questions which are very, very important for us. Can we have the questions, please, from the house?
Yes, madam. You said the treatment part of hypercalcemia covered furosemide, but furosemide will cause hyponatremia too, right? So how will you manage that situation?
Yes, exactly. That's what
both are emergencies. Like hypercalcemia is also an emergency. Hyponatremia is also an emergency. So treatment of one emergency will cause another one.
I understand that. So that's what I meant when I'm talking about monitoring for the levels of it. When we generally tend to give furosemide, we don't give dosages around 40 to 60 per day. We give it around like 20 milligram push IV only after 1000 ml of fluid. So when we are looking over 24 hours, approximately 40 milligrams of Lasix would have been given, and that generally wouldn't have had caused much of hyponatremia if patient already had normal levels of sodium.
If the patient is having hyponatremia also?
If the patient already has an hyponatremia, then based upon your calcium levels, there could be various other reasons why the patient has hyponatremia. So do a workup for SIADH at the same time, see whether that is also one of the reasons for it, then manage both the electrolyte abnormalities.
In the case, we will hold off. Not give.
Okay. If you're not give, in the sense, we have to monitor the fluid intake for this patient, because you'll be giving overt hydration and the patient will not be passing that much amount of urine. It will go into fluid overload. So while you're giving that, same time, make use of other agents, that is bisphosphonates and salmon calcitonin, to manage the hypercalcemia at this point of time when you can't give overt hydration for this patient.
Thank you.
Welcome.
There's a question in the chat with, from Dr. Usha Raghavan. Indications for home oxygen.
Indications for home oxygen in dyspnea. Unless and until, madam, if the patient is not hypoxic, oxygen does not really cause much of a benefit for the patient. So instead of using a fan directed at the face or a hand fan, keeping the room open, keeping the room fan always on at a little lower speed at least. So that will help in patient feeling better, using various positions for the patient to sit, like an upright posture, using that table in front of on the bed, so that they can have a forward bending posture. Asking them to use various breathing techniques will help in preventing dyspnea if there is no hypoxia. But if there is hypoxia, then yes, it is warranted, because in patients with lung metastasis, they can be sometimes presenting with hypoxia, lymphangitis carcinomatosis. They can have hypoxia. That time you can ask the patient to have like a concentrator or a cylinder with very small, low dose, like 2 liters, 3 liters oxygen being delivered. But at the same time, using other medications like morphine, using benzodiazepine can also help relieving the perception of dyspnea. So it's a balance of all of these things together. It may not be one way or the other way out.
fact, we generally in palliative care, we go for, the non-pharmacological methods rather than, keeping an eye on how much oxygen to use.
Yeah.
So regarding the previous question on hypercalcemia versus hyponatremia, I think Dr. Sanjay Pandya has very rightly pointed out, balancing out the both, because of course one is cardiotoxic and then one is neurotoxic. I think, thank you, Dr. Pandya, for that. And any other questions that are there, or otherwise we can actually move to the case presentation, and I'm sure we'll have many questions on that particular case also. Can we move on?
Just one,
Yes, yes.
ma'am, just one
Yes,
question, ma'am.
Yes,
The
please.
thing is, many times in the emergency rooms, we see that the our patients, those who are suffering from terminal cancers, they land up in medical emergencies, maybe in altered sensorium and the difficulty in breathing. And the relatives, they insist that please doctor, do something about the case. He is having difficulty. And we see that the saturations have dropped down to 70, 80, something like that. And then when we know that this is a terminal case, and we putting the patient on ventilator may be a futile effort, but still the patient relatives, they do want that the patient should be intubated. What should be done in that case?
I I think at this point of time, is this a patient who will be on regular follow-up on OPD also, or something? What is your background, Dr. Nitish? Are you an emergency physician?
I'm an anesthesiologist, ma'am. Yeah,
Okay,
so many times since we are looking after the ICU and we do get a call of many times that the patient, such a patient has landed up. Today
yes.
only, in fact, I
Yeah.
had one case of hepatocellular carcinoma. Patient is in a very debilitating condition. Patient relatives want something to be done, and patient is not maintaining saturation.
At this,
Pardon?
I completely understand your situation, sir. And when even we have had such even instances when I was in my residency, even now when we practice in our EMD. So the first and foremost is, while you're trying to find out the cause, what is the reason that this patient has sudden onset or is in an altered sensorium, and before that, a open communication with the family, letting them know this is what the situation is, what is going to be futile for this patient, what will happen if they do this, and what will not happen, a clear cut idea given. Very often they would be very acceptable of your thought process and will agree to your suggestions that doing this would be futile. Maybe that length of conversation may not be a usual 5 minute, it may go on for 30 minutes also, but explaining in detail about what is happening and why do you think it is futile, family will generally understand that. Just that they may not have had somebody telling them, expressing them these are the situations, so they don't know what is the right decision to be made. But when explained, your job will be more easier at that point of time, so you would not waste your time doing futile interventions, but rather explaining and then looking at end of life care for such a patient.
Yeah, and I also believe that the thing is basically, since the patient is a regular visitor to us, this kind of counseling should be engraved in their mind that
Yes.
they may land up in such situation, and
Yes.
what should be done exactly at that point of time.
Yes, I very
So
much agree with
so
that.
yeah, so and maybe they will be better prepared for such eventualities.
Agree. An anticipatory counseling session, like when you see that the patient is really not doing well, has a regular follow-up in the clinic and is deteriorating now, family is coming to you saying, that is your trigger to initiate this conversation there and there, that look, we feel that patient is not doing well, can have these certain situations, what you would want to do at that point of time. We recommend 1 2 3 because these are the reasons, this is the reason it will be futile if you do it, and patient will have very bad quality of life in the ICU with all life sustaining treatment ongoing, and may not really be a fruitful outcome. It will be more of a financial burden on the family too. So when these discussions are happen anticipatory, in OPDs or clinics, or maybe home visits when when the team is visiting. That can help a longer way in avoiding such patients presenting to the ED.
Absolutely.
May I add one thing, madam?
Yes, sir.
Because this type of situation, because myself is also an anesthetic, this type of situation usually happens where the palliative physician is not available. And the regular physician, they insist that we should resuscitate and we should intubate and help them. But they don't have explained, they have not explained to the patient in a previous follow-ups if such thing can happen. Where these palliative physicians are not available, this situation is always there, and if we go to explain them, then they will, a primary consultant will feel that we don't want to do the work. So it is difficult situation at that point of time, whether we should explain to them or not, because they are not under our treatment.
Correct, sir. I
So this
completely
is the
understand
problem of
your
a lack of a
perspective.
palliative physician.
Yes, I mean, I've been working at this institute for the past 2.5 years, and believe me, when we initially came in here and we started this OPD, it was also as difficult as you're explaining to me right now. It's more of a perception change, and also more of administrative policy changes also coming in that will help you do this in a better, effective way. Because unless people don't realize that such discussions can have these impacts, they may not be able to agree for it. Once they have experienced it, seen it, how it really changes the management, it has a longer way. Like, we now do such sessions in the ICU. We have sensitized clinicians in the ED, and that has led to us being they have already done those discussions. It's only when the family is agreeing, then they will call us that, okay, now it's end of life care, why don't you take over from here and provide that care. So it's about more of awareness that needs to be done amongst them. So this is one of your ways, sir. You doing this program is that you have got into this, and you could spread this awareness within your institute wherever you're practicing amongst other physicians, knowing that such and such approach could also be considered.
Absolutely, Krithika. I completely agree with you, because whether we are also, I mean, in situations where you have the non-clinical staff perhaps becoming a kind of small obstacles, because they are also not sensitized to this particular concept. So one step at a time, maybe conducting some sessions for the non-clinical people, and then of course sensitizing your own clinical people, and of course taking the higher consultants, like into your boundaries, I would say, making friends with them, and then sneaking this idea of how you can actually bring about a change even when the patient is just in the last hours of life. I think that should make a difference, and that's absolutely sensitization.
Yes.
Yeah. Dr. Pandya, are you satisfied with this answer?
Yeah, I'm okay with that, but it has to be initiated by someone.
Yes, I think so. As Dr. Krithika said, you are the person now, so you need to do that. You have to have this responsibility.
Yes.
We are happy
Sure,
to help, sir.
sure.
Yeah, of course.
I just wanted to share one instance. Maybe a few days back, maybe a week back, we had basically done a case of right hemicolectomy for a CA-seeker, and patient was on ventilator because immediately within the during the surgery only the patient started having very low BP. And what we did is we immediately wheeled out the patient after the surgery and kept on the inotropic support. But at the same time, we counseled the son and the his wife about the patient's condition. And then we kept on regular sessions with them and updating the patient relatives about the condition of the patient. And whenever we allowed them to come inside the have a look at the patient, at the same time, whenever we took an opportunity to explain the condition of the patient and whatever their queries were, we addressed all those queries. So even maybe day before yesterday night, when she was very critical, again I went there. Again, did counseling along with the GI surgeon. And we found that the moment we came back, we found that the patient is arrested. But they at least they accepted the whatever the outcome was with some at least they didn't was not angry. They were not fighting with us. At least that is what I feel that the counseling is very important, and right throughout the time you should counsel the patient relatives so that their whatever their anxiety, whatever they want to know about their patient, at least that is satisfied.
That's very important, sir. And it is, so you brought out a very big point about communicating timely and preparing the family of, it's like planning for the best, hoping for the best, and also planning for the worst. Like, we don't know what could happen, but that itself can bring about, like, you're giving two plans. Whatever can happen, people are ready, and you know at what point of time what can happen, and they face it because you had discussions at length with them prior. So it's very important to have communication intact.
So I think we can move on to the case presentation. So it will be by Dr. Tuba. So over to you, Dr. Tuba.
Yeah, hello.
Yes, Doctor, we can hear you.
Yeah, good afternoon, everyone. I am Dr. Tuba presenting today's case. Can you please share the slides?
Can you see the slides? I have shared it.
Yeah,
Can
yeah, just move. Okay, today's case is about a 17-year-old female who was diagnosed with osteosarcoma, small variant, D6, D8 lesion with spinal cord compression with paraplegia with stage 3 pressure sores. Next slide, please. Yeah. She came with the complaints of having backache, inability to walk, bed sores over sacral region, gluteal region, and posterior compartment of both the legs, and swelling over both the legs. So her history is she is a 17-year-old female with pain in the lower back. Pain was severe, continuous, and stabbing in nature. She had already been treated with some medications, but there was no relief. Her investigations revealed that she had a lesion involving D6, D8 vertebra, bilateral ribs, particularly 6 and 7, causing compression of the spinal cord. She was advised for surgery and a dorsal laminectomy of the vertebra with decompression of the tumor with fixation using horseshoe implant was done in a government hospital, followed by only one cycle of chemotherapy as her general condition was not fit and there was a financial crisis too. Soon after the surgery, she was unable to walk. Due to restricted movement, she developed sores over the sacral region, gluteal and posterior compartment of both the legs, and she also had swelling in her legs. Next slide, please. On examination, patient was conscious oriented. Her vitals were normal, but on systemic examination revealed weakness in her lower limbs, decreased tone, decreased reflexes. The rest of the systemic examination were within normal limits. Okay, her pressure sores were painful, discharged with foul smell, and irregular in shape. Okay, on routine investigations, her hemoglobin was 9.8, total count 8,900, platelets 3.8 lakhs, serum creatinine 0.47, sodium and potassium 137 and 3.22 milligram per deciliter. On treatment, she was treated by giving Pantop 40 milligram, one tablet early in the morning. Morphine 10 milligram was given to her 4 hourly. Metronidazole powder added to white petroleum jelly was asked to spread over the wound. So her psychosocial aspects, she's a 17-year-old Muslim unmarried girl living with her elderly parents and 2 younger brothers. One of the brothers, who was the sole bread earner, is now taking care of parents and sister, thus is not able to work anymore. They have no source of income. They had taken some amount from their relatives for her treatment purpose. Presently, their financial condition is very poor. Okay, her main concerns are pain, paraplegia, pressure sores, and poor financial condition. So the summary of today's case is that she's a 17-year-old female with osteosarcoma small cell variant, D6, D8 lesion with spinal cord compression with paraplegia with stage 3 pressure sores. And today's discussion points will be like, how can we prevent SCC to happen in this patient? Will radiation be useful for this patient? Can physiotherapy help in making this patient mobile? Is there any role of steroids in managing the patient? How can we prevent the pressure sores? What is the prognosis of the patients with squamous cell carcinoma due to malignant and non-malignant cases? Thank you.
So we already have had a good presentation on the emergencies, and the first and the foremost emergency that Dr. Krithika had discussed was spinal cord compression. So I would invite suggestions and answers to all these questions from the house. So how can we prevent SCC to happen in this patient? Can anybody enlighten us with their answers? You can put your chat answers in the chat box also.
Can I answer?
Yes, please.
Yeah, this is Dr. Rakesh Mittal. I am a medical oncologist.
Yes, sir. Yeah.
I just want to know, is it the primary site of the disease or it was a osteosarcoma in the limb? I just forgot to check.
No, sir.
Where was the primary lesion?
The primary site was the, it was not in the limb. It was D6, D8 compression only.
Oh, this is a primary
yes.
osteosarcoma of the spine.
Yes, sir. Yes, sir.
Okay. So this is not very common, but the only treatment, there is a very hardly any role of radiotherapy in osteosarcoma.
Okay.
So the only treatment for oncological treatment is chemotherapy, which we see is very difficult in this case now because of this
paraplegia,
bed sore and paraplegia and poor financial conditions. So that is a very unfortunate situation. But in this case, we are talking about the spinal cord compression, which is the presentation itself. So we really can't say how to prevent it because it is a presentation itself.
Okay.
Okay. Any other comments on the question, on the first question? So, Dr. Krithika, can you please enlighten us on this first question, like preventing the cord compression actually?
I completely agree with Dr. Rakesh Mittal's view on this, that because it was the initial presentation, so it's very hard and difficult because unless something is going wrong, patients will also not present to the clinic. But what if this was a primary site at somewhere else, say a limb, and the patient has now, say, presenting with back pain for a very long time? You could educate the patient before that, pain anywhere else, if they notice, then it is better to come to the OPD and report at the earlier. So had this been caught, like in the pain is there in the back for a very long period of time, say like past 2 or 3 weeks, and if the patient would have presented with that, with some weakness also being also noticed later on, so that way you could at least prevent the complete cord compression. You could start treatment earlier, identify and start treatment earlier, and prevent complete paraplegia to happen there. So rightly pointed that if it's initial presentation, you can't do anything to prevent that. But had this been something like a metastasis, yes, educating and preemptively explaining to the patient and the family of symptoms that can occur, like as I gave an idea, what would be the most common cancers presenting with both metastasis. So explaining that, there's a chance that if there's already a metastatic disease, it could also spread to the bones, or if there is a documented evidence of bone mets, may not be vertebral column, but somewhere else, there's a chance that it could also spread to the vertebral column. So anticipatory discussions help in preventing it.
And I think if we think about preventing symptoms, then perhaps maybe we can think about preventing the fracture that might happen in that particular site, because it's a osteosarcoma is a lytic lesion, and that might lead a more of a kind of a pathological fracture for this patient, and we can surely think about preventing that to happen by managing that. Maybe if we can jump to the fourth question, is there any role of steroids along with the role of radiation? Will these two can be combined as one question, and then we can seek answers for that?
Although there is no role for radiation therapy in osteosarcoma, but in this case, since it is a primary bone lesion, we could try radiation in this case. At least it might reduce edema. That is what I feel. But as such, in osteosarcoma, the role of radiotherapy is very limited.
So, Dr. Mittal, we are actually talking about the compression that has already happened to this patient.
Yeah.
And I certainly think that radiation and steroids are the mainstay of treatment.
Definitely, but it all depends how many days have passed since the presentation, because the radiation and these work in early within first week of time. But if already 3-4 weeks have passed, and so I don't think radiation will have much role in this case.
Radiation could also be used for the purpose of pain.
Yeah.
If the patient, that could also be the intent of giving radiation in this particular patient. It could help in that way, that your regular analgesics are not helping. When one fraction radiation could bring down the pain intensity.
Like
And
palliative RT, like palliative radiotherapy for the patient?
Yes, it will be a palliative intent radiotherapy, not definitive.
Okay.
Only for pain management.
Yes.
Okay, fine. And what about physiotherapy? Like radiation, she can only get when she'll be able to like move. She's bedridden completely. Like she's not able to move totally at all. She just got paraplegic soon after she was operated, and so it's very difficult for her to come even to the hospital for the radiation.
So usually what we have seen is radiation is not given over few days. In such a case, they would rather prefer to give it as a single dose, one dose, and that's it, for the purpose of reducing pain. And your second question about the physiotherapy, if in a patient of paraplegia due to spinal cord compression, there is physiotherapy can only help in reducing the contractures and preventing the stiffness, may not really help in like how in neurological cases, like non-malignant neurological stroke patients, where rigorous physiotherapy might bring up the power of the muscle groups. Here it may not, because it's a complete cutoff of the pathway itself. So here it might only help to prevent contractures and keep some joint mobility intact that way. So that physiotherapy can help in that way, but not rigorous, maybe just movement, passive physiotherapy.
To some extent, like can it make her mobile?
That's very difficult, because as everybody pointed out, she was paraplegic immediately after the surgery, and she already presented with weakness since 1 week. So that's been a long gap, and usually who have persisting paraplegia, despite all interventions being done, there is very less chances of complete neurological recovery, or even less. It may be very, very nil, almost close to nil is what we've experienced. So that telling the family that it may occur is like raising the bar of hope, and they would constantly do things to continuously do that. So it is better to be telling them that it's unlikely that it is going to come back. So she may be bed bound for a longer time, and so then your care will be more towards how to manage a paraplegic patient with bowel care regimen, bladder regimen, prevention of bed sores, back care, bed care, all of that.
Yeah. Okay. Thank you, ma'am.
And we can actually anticipate also certain other factors, like osteosarcoma generally metastasizes very soon to the lungs, Correct me if I'm wrong. I think that will be one thing that we can actually think about, because there'll be a lot of lung issues with such patients very soon. So I don't know. Does anybody have a comment on that?
That is bound to happen, Dr. Sangamitra, because we are hardly able to do anything for her osteosarcoma. We are not able to give her chemotherapy. So if we are not able to treat her by giving her the only treatment, which is the chemotherapy, the disease is bound to metastasize. And as you said, the lung is the most common site in osteosarcoma. And then she will have all the symptoms of lung disease later on.
Okay, preventing the pressure sores. We already had a good pressure sore session. We had a session on pressure sores. So can anybody talk about the pressure?
Yes, ma'am. The thing, pressure sores definitely can be prevented, and with the proper positioning of the patient and taking care of the skin and hydration of the patient, which all the points which we had discussed in previous lectures also. So if we take all care of all these things, we have use water beds or the alpha mattresses which are there, or this, and then we can basically use massaging the pressure points which are there, the bony prominences which are there. Definitely, we can prevent pressure sores among these patients. And in fact, I will just say we had one patient with GBS. She was with us. She had GBS on 10th June 2021, and she got discharged on 3rd of December. She didn't had a single bed sore, and she was absolute on a ventilator for almost around 5 6 months, 6 good months, but she didn't had any bed sore. So it is credit, ma'am. The credit does not go to me, ma'am. Credit goes to the nursing care, ma'am. I absolutely say, I hats off to them. They have done a remarkable job, and they had done wonderful, ma'am. I think a 6 month patient on ventilator without any bed, so it is remarkable.
You are blessed with a very good team, I must say.
Ma'am, and army, ma'am, we are, ma'am. We are very categorical about that. The thing, if it happens, then in that, the nursing staff is very good. No doubt about, and but at the same time, ma'am, we have resources also.
Any other comment or questions? Please, most welcome.
On this point,
Ma'am,
yeah, continue, Dr.
yeah, actually, the thing is, she is the only female like in living in her family. Her mother is too elderly to take care of her. Plus, they live in a very far-flung area. Plus, the financial condition is too poor to like to get the like water mattresses or air mattresses. So like it's like very difficult for them to like prevent actually the bed sores.
yeah,
No doubt they are changing the position every 2 to 3 hours, but like it's already being the condition is already getting worse for her.
I would like to add a point here. As you
Yeah.
mentioned that one of the only female caregivers in the family, but at least from the point of trying to keep a fan on in the room, change her positions. And instead of using an air mattress or a water bed, even gloves filled with water and keep it
Okay.
all on the pressure points on her body. So in her buttock region, under the heel, under the shoulder blades, on her under her elbows, all of these pressure points which are there touching the bed area, you can ask them to fill gloves with water, keep it a little softer, not very tight, and that could be just used under those pressure points. That
Okay.
could prevent the friction between. So tell them that instead of using a very thick bed sheet or a blanket, they can use a little softer one. So that way the friction forces do not shear the skin, and that way it will prevent further bed sores to form in. And at least just they could, somebody in the family could, if not needed to lift her up or move,
Yeah.
the brothers help to turn to one side while the mother just applies powder on the entire back, make sure that it is dry. That will also be enough from the family's end to make some effort towards preventing a bed sore.
Thank you, ma'am. Sure.
Okay. Any other question, comment?
It's actually a good idea for the patients who are in a poor financial condition who cannot afford to get air mattresses.
Yeah.
Actually, Dr. Krithika, thank you so much for sharing this lovely idea. It's absolutely
Yeah.
wonderful. I am going to do this with my patients also.
Yeah, everybody's gonna do this.
It's most cheap and effective.
Yeah, thank you,
Absolutely.
ma'am. Thank you.
Absolutely. Thank you so much.
Most welcome.
Box. No. So if there are no questions, it's
Ma'am, the
already.
last question, what
Yes,
is the
yes, please.
prognosis? What is the prognosis in patients with who are with the non-malignant and malignant causes? How, like, what is the prognosis in these patients?
For the malignant lesions, it is very bad because disease will spread very fast without treatment. And I don't know the time frame, but it could be anything less than 6 months. But I can't comment upon the non-malignant condition. They may survive for much longer time. Dr. Krithika can comment.
Usually, when you talk about prognosis in this, one of the important things that can help you is the palliative prognostic index. There is a scale which takes into account a lot. So it's an objective assessment one. So it takes into the performance status of the patient, certain biochemical values, patient's oral intake, hydration status, everything into account. So if you search about PPI, palliative prognostic index, that's an objective assessment. So it gives you a time frame of whether a patient has time in days up to 2 to 6 weeks or more than 90 days. So that way it can help you get a guess. It could affect, but patient might develop certain, maybe they're immunocompromised, cancer burden increases. There could be certain other events that could hamper that index that you would have seen. Other way, in such way, is when you're talking about discussing about prognosis with such family members, with the bed sores being grade 3, meaning already there is quite a lot of extensive damage, and grade 3 bed sores will develop infections and could lead to a point of source of sepsis for her. So unless they don't control that, she might have a much more shorter duration. One way that you can talk about prognostication with the families is looking at as an estimate of how they see the patient deteriorating, whether it is over a period of days, over a period of weeks, like, week by week the patient is going down, or day by day. So then you can give that the patient has, say, week by week deterioration, so time is in weeks. Day by day deterioration, the time is in days. So it's always that you can estimate and tell and discuss about prognostication, because there are various factors, variables that are involved in her case especially, which can affect her prognosis, not related to cancer, but more so due to her debility, her being bedbound with grade 3 pressure sores. That is one which could further worsen her overall survival.
Can I ask one question to Dr. Tuba?
Yes, sir, sure.
Dr. Tuba, have you reconfirmed her diagnosis by
Yes.
reviewing the pathology?
Yes, sir.
Because in spinal area, the Ewing sarcoma is much more common than the osteosarcomas.
No, sir. It's a case of osteosarcoma
Okay,
only.
then
I
it's
have
okay. Because if
I
it
have
is
seen I have seen all her documents, everything. Then I made up the case. I have seen everything related to her.
no, but have they got it reviewed? You must have seen the
Yeah,
documents.
yeah. They have got it reviewed. It's a confirmed case of osteosarcoma only.
Then it's okay. Then it's okay.
Dr. Krithika, I had a question actually here. In non-malignant SCC, do we generally, anticipate a recurrence of compression,
Disease.
do we do that? Do we anticipate recurrence?
Non-malignant, I mean, it would be like by a trauma, a fall, or it could have been due to vitamin B12, folate deficiencies that can cause, or it could have been due to an RTA that has happened. So therein, generally, once there is a cord compression at a particular level, unless there are multiple cord levels involved and there is instability and that part of the spine is not stabilized, then there could be a chance, but depends upon whether it's higher up or lower down of the presenting or the present time wherever the cord compression was. So non-malignant wouldn't spread like how malignant would have had an impact, because we've seen like that. We've seen patients with malignant where we've treated one area, patient got better, paraplegia was not set in, was able to ambulate within a span of 4 weeks. Higher up, there was another cord compression, and that led to complete paraplegia for that patient. So very unfortunate. But when we did not suggest for surgical stabilization at that point of time, because you can't stabilize at multiple points in a malignant cause. But whereas in a non-malignant, yes, if it's due to trauma, fall, fracture, you can consider stabilizing, and that could help to prevent, further instability leading to spinal cord compression.
Okay, if there are no more questions, I think we can wind up. I can actually hand it over to Rajlakshmi. Thank you so much, Dr. Krithika, Dr. Tuba, and the whole team for this wonderful session. Especially
Thank you
Dr.
so much,
Krithika,
ma'am.
we actually learned a lot. Yeah, thank you.
Thank you so much, madam.